All right. Thank you, Dr. Dahl.
Yeah, welcome on this Wednesday in December. Wow, already. And I'm just excited that we don't have snow and it's actually 30 plus degrees. So that's something to be thankful for. We'll get going today. The videos and the topic is cohorting for infection control and prevention. So I'll just do a little brief overview and we'll get to the video. The objectives of today are to understand the goals of cohorting and to discuss the challenges when trying to create appropriate cohorts, to describe dedicated COVID 19 units, to consider cohorting residents with potential exposure, and describe monitoring new admissions and readmits and creating an observational unit for them. And so cohorting is just grouping residents based on their risk of infection or whether they are positive for the COVID infection during this outbreak. And we're doing it to attempt to decrease the spread in our nursing homes. And this is just another way to look at it. In addition, we have to cohort the staff. So the staff should be limited to the different cohorts as well, and they should have separate break rooms, or else they're the ones kind of spreading between those different cohorts. So just a reminder there. Here's just another way to look at how we can cohort people. Basically, if they're positive, they all have to be in the positive area. If they're negative but exposed or symptomatic, then they should be in kind of the observational area and then move to the positive when they become positive. Or if they're negative, they can go back to the negative area, and then there should be the COVID negative area. And I wanted to briefly talk today about kind of symptoms. And I noticed I was on call not too many weeks ago, and I was getting calls, and they were, so and so tested positive for COVID, but they have no symptoms. And then as we continued to talk, they said, well, but they are confused, way more confused than they usually are, and fatigue and sleeping all day. Well, that's their symptom, right? And the older adults, typically 80s and olders, we are getting these atypical symptoms and the delirium, right? So it's basically their presenting symptom is delirium for COVID, and they don't necessarily get any of the other symptoms that are common to us. So I think we have to be educating that the delirium, confusion, fatigue, sleeping most of the day, that is a symptom of COVID. And so we have to be suspicious when people present with these symptoms, or their confusion changes during this time when there's other positives around them, and recognize that in addition to all the common ones that we know is a very likely symptom in these older adults. So just wanted to stress that. Otherwise, we can go straight to the video today.
Yeah, we're waiting for the video where people are just kind of listless, lying around. So that's a form of delirium for sure.
My name is Kara Jacobs-Slifka, and I'm a medical officer with the long-term care team at Centers for Disease Control and Prevention. And I'm also a part of the COVID-19 response infection prevention and control team. And so today I want to talk with you about cohorting and critical infection prevention strategies. So I have no financial disclosures to report. And the learning topics that we have for today are ultimately involving cohorting. So I want you all to understand the goal of cohorting, but I want to talk about some of the real challenges when you are trying to create resident cohorts. We are going to talk about dedicated COVID-19 care units and some considerations for when you are trying to cohort this group of residents with potential exposures. And then we'll talk a little bit about new admissions and readmissions and what options you have there. So before we go any further, I want to make sure that you know where you can go back to for more information. So this is the website for our COVID-19 infection prevention guidance for nursing homes. And this has a lot of resources available for you. I definitely encourage you to turn here with questions. So let's talk about cohorting. Okay, so the ultimate goal of cohorting is to minimize the risk of exposure and prevent additional spread. We're typically talking about residents here who have the same infectious pathogen. So in this situation, these are residents with SARS-CoV-2, or that we are concerned for SARS-CoV-2. And it's probably easiest to think about this in that group at the bottom that have confirmed COVID-19, because we already know for these residents that they definitely have COVID-19. It's probably also relatively easy to think about or understand the idea of grouping together people who we don't think have COVID-19. Now, granted, it's probably not entirely appropriate to refer to them as being COVID-19 negative, because they may or may not have actually been tested, and we know that testing just reflects a single point in time. So we tend to think about them more as being COVID-19 unknown, because they could become positive at any point. The groups that are a little bit more difficult to explain and think through are these other two groups. The individuals who have some kind of symptoms, and you might be suspecting COVID-19, and that group of individuals that have either a known exposure or a possible exposure to SARS-CoV-2, the virus that causes COVID-19. So I'm going to use an example to help us work through this. And I'll preface this with saying that if you want to pause after we describe this and have a little bit of discussion, and then move on with my video, you're more than welcome to, or you can continue to work through and have discussion at the end. So Mrs. Davis, she is a resident on Unit 4 South, and she has recently tested positive for SARS-CoV-2. And so you've now moved her to the area of your building that you have dedicated for residents with COVID-19. So a little bit about her. She spent most of the time of her day in her room, but she did occasionally leave her room and walk up and down the hallway with assistance each day. She does have a history of chronic obstructive pulmonary disease, COPD, and really couldn't tolerate wearing a cloth face covering. Now, she does have 2 roommates, and there are a total of 18 residents residing on her 4 South unit. So the questions I have for you is, how should we approach the rest of the residents on Unit 4 South, on her unit? Should we be thinking about moving exposed residents? What about her roommates? And why or why not? Or where or how? Should we be taking her roommates to the COVID-19 unit? Should they go elsewhere? Stay where they're at? These are some of the things I want you to think through. So the reason it is challenging to think about this is because the extent of exposure, one, that's a little difficult sometimes to truly know, and then the risk of the developing infection can vary, and that can make it difficult to make some of these decisions. So, for example, Mrs. Smith's roommates, they've had pretty close contact with Mrs. Smith. They have had direct exposure to someone with known COVID-19. And so they most likely have a higher risk of going on to develop infection. But it doesn't necessarily mean that they will for sure go on to develop COVID-19. You also have to think about the other residents on that unit. They probably don't have the same level of exposure as Mrs. Smith's roommates, but we don't know that for sure. It doesn't mean that they haven't had exposures. They may have. And even with more limited exposures, there still is the risk of them going on to develop infection. Another way you can think about this, or some other groups of residents you can think about this idea with, are those who are newly admitted or readmitted. or even those who are regularly leaving the facility, like for dialysis. They may have had exposures, but they may not have. It's a little unclear, but they are definitely at risk of having had an exposure to someone else who has COVID-19. And there are a lot of things that factor into this. So, for example, the IPC practices that were being used where these individuals were located, and the prevalence of COVID-19 in the community. If the prevalence is much higher, there's probably a higher risk that they could have been exposed. So when you think about these individuals who may have had exposure, if you are trying to move all of them and group them together in a different area of the building, it's possible that you are now combining residents who had a very extensive exposure and may actually go on to develop infection with residents who haven't actually had an exposure at all. You're worried they might, but you don't know for sure. And you could end up putting them together in another part of the building and actually causing exposures. So you have to really think through the risk and benefit of doing this. Again, the goal is to minimize exposures. The other challenging thing is that once you start moving residents throughout the building, as you all have probably experienced, it can quickly become very, very complicated. And you can end up moving far more residents in the process than the number that you actually want to relocate. So another challenge with defining cohorts and thinking about movement of residents is that residents with symptoms don't necessarily have SARS-CoV-2. We know that symptoms are not always a reliable way to detect SARS-CoV-2. So early in the COVID-19 outbreak, we found that about 30% of residents who had symptoms that were consistent with COVID-19 actually went on to test negative for SARS-CoV-2. And then we've also seen the opposite, where asymptomatic residents or residents who were pre-symptomatic, they have no symptoms now, but in a couple of days go on to develop symptoms. We've seen those individuals actually having COVID-19. And there's the potential for those individuals to then spread the SARS-CoV-2 virus. So it's important when we think about symptomatic individuals that that is not a reason to move someone to a COVID-19 unit. You want to make sure that you are actually confirming that they have COVID-19 before you would move them to a dedicated COVID-19 unit. So that brings me to our next point, that because of how complex this can be, we recommend that your first priority be to create a separate dedicated area for confirmed COVID-19 cases. This is a space that should be designated only for COVID-19 care, so not for anyone with pending testing or exposures or symptoms who have not been confirmed to have COVID-19. We do recommend that you try to have this area physically separated from other rooms and other units of the building, and that you dedicate staff as best as you are able to this unit. Ideally, there are staff that have clinical expertise and training, and that you do have also dedicated equipment and plans for meeting the needs of these residents, because we have seen these residents with COVID-19 developing potentially serious illness, and sometimes that happens quickly. We do also recommend considering developing a plan for managing areas of the building when confirmed COVID-19 is detected. So in the example I shared with Mrs. Smith, she was confirmed to be positive and was moved to the dedicated unit. But my question for you was, what do we do next? What do we do with the rest of this unit? So our guidance recommends, CDC's guidance recommends that you really try to approach the entire building if you are able to, and consider testing and using transmission-based precautions, because what we have seen during this outbreak is that once you find one case of COVID-19, if you look, you will find others. And you want to identify them as early as possible so that, again, you can prevent spread and additional exposures. However, we do recognize that sometimes it is challenging, and because of testing resources or PPE or staffing resource issues, it's hard to focus that broadly on your entire facility. So we recommend that you at least consider thinking about using transmission-based precautions and performing testing on that unit where that individual with COVID-19 was residing. And then once you do confirm individuals are positive, that they then are moved to the dedicated COVID-19 unit. So I want to use this somewhat simple facility layout to walk through describing this. So this is actually from a nursing home that CDC and others were deployed to at some point during this outbreak. And this picture describes how they laid out their building. They were able to dedicate an entire wing of the building to individuals who are COVID-19 positive. And they were actually able to dedicate a smaller area separate from the COVID-19 unit where they brought in new admissions and readmissions. And then the rest of the facility was pretty much dedicated to those who were presumed to be COVID-19 negative. Now, say someone, you suspect they have COVID-19, or in the case of Mrs. Smith, you have now confirmed they have COVID-19. In addition to moving that person to the COVID-19 unit, the question now is, what do you do with the rest of these presumed negative individuals? And so as I've described, our recommendation is that you focus on this entire area in the blue color, and you try to use transmission-based precautions and perform testing. But again, we know that's not always possible. So if you need to limit or focus on a unit, you want to focus on the unit where that individual with COVID-19 was newly identified, because this is the unit where there is the highest risk of exposures, or where the highest risk exposures have likely occurred. And so in this situation, you would focus your investigation here, place all of these residents in transmission-based precautions, where they should be restricted to their rooms as best as possible. Staff should wear N95 respirators or face masks. If you don't have respirators, they should be wearing eye protection, goggles, or a face shield. They should be wearing a gown, and they should be wearing gloves. And you should be testing all of these individuals. And you should test them about every 3 to 7 days, and repeat that until you've gone at least 14 days with no new positive results. Now, anyone who's identified, any resident who's identified as being positive, should now be moved over to that COVID-19 positive unit. And if you have concerns that there are residents in other units who are symptomatic, or you find staff that test positive, then you need to expand that testing to the entire presumed negative area. So since I did in this example, and I have talked a little bit about this observation unit, I did want to discuss considerations for when you are trying to create a unit like this. So we do recommend that depending on COVID-19 activity in your area, that you place residents who are newly admitted or readmitted into a single person room or an observation area where they're cared for in full PPE, so transmission-based precautions, for 14 days, because we are concerned that they may have had exposures and could go on to develop infection and spread SARS-CoV-2. Now, ideally, these individuals go into single-person rooms, but again, that may not always be possible. So what you really want to avoid are where you're placing multiple people with different exposures into shared rooms. So for example, placing the roommate of Mrs. Smith and placing a newly admitted resident into a shared room is not something that we'd recommend. If you can avoid that, we'd recommend avoiding it, because you have someone with a close exposure and someone with a possible but uncertain exposure. Now together, it's possible that you could end up with an additional exposure and possibly spread of SARS-CoV-2. As I mentioned, you want to make sure that you are using all recommended COVID-19 PPE and transmission-based precautions for these residents. We do know that with shortages of PPE, there are some strategies that you may need to use, some of the contingency and crisis strategies. However, extending the use of gowns specifically, so wearing the same gown for the care of more than one resident, is not something that we recommend on a unit like an observation unit. Extended use of gowns is a crisis strategy. It's a strategy that you use when you are pretty much out of gowns and you are caring for individuals who all have the same infectious pathogen. In an observation unit, you are concerned that they may have that pathogen, but you have not yet confirmed it. So again, using those same gowns for multiple residents has the potential to increase exposures. And we're not just talking about SARS-CoV-2 here, we're also talking about other pathogens, C. difficile, MDROs, Candida auris. So this is not a recommended practice. And then last, testing at the end of that 14 days is something that you can consider to increase the certainty that the resident's not infected. But testing earlier on is not something that should be used to discontinue precautions and move those residents out of the observation unit. So we're at the end of the information I wanted to share with you. I just wanted to go back through and pull out a couple of the key points that I hope that you take away from this talk. So the goal of cohorting is to minimize exposures and prevent additional spread of SARS-CoV-2. When it starts to become complex and challenging, I encourage you to step back and remind yourself what the ultimate goal is and ask yourself, is what I'm doing minimizing exposure, or could it contribute to additional exposures? When you are creating those cohort areas, prioritize space for those who have confirmed COVID-19, those who have actually tested positive for SARS-CoV-2. And think through the risks of putting people together who have had exposures. That extent of exposure and the risk of developing infection may actually vary quite widely. So use caution when you are cohorting this entire group of residents together. My suggestion to you is that instead of moving residents to an exposure unit, or what many people are referring to as a yellow zone, consider actually turning that high-risk unit where you've had a newly identified resident with COVID-19 into a yellow zone, at least temporarily, and have those residents shelter in place in transmission-based precautions while you're doing your testing. That way, those who are exposed are staying where they're at and you're monitoring them. And then once you've gone the 14 days without any new individuals testing positive, you can go ahead and lift those precautions. I have a couple of pictures here just to show you how others around the country are making this work and the types of barriers that they have been using to physically separate their dedicated cohort for their COVID positive individuals. In the center picture, towards the back, you can actually see that they have built a temporary wall. And then I last wanted to point you out to one more web page. This is actually our long-term nursing home and long-term care landing page, where you will find a link not only to the guidance I showed at the beginning of this presentation, but also to numerous other documents, testing, assessment tools, and some training materials as well. And I thank you very much for having me. I hope the rest of your discussion is productive. Thank you so much.
All right. I'm assuming, since we're in pretty hot spot, that we're doing most of these things on a regular basis every day. I don't know if anybody has any comment about the video before we move on to case studies.
Dr. Dollar, looks like there's a couple of questions in the chat. One of them from Cindy is, will the new CDC guidelines dropping from 14 days to 10-day quarantine be adopted for long-term care also?
Right, and I agree with Dr. Geriatrics' response there that we haven't heard yet. My guess is that they will probably go to the same, but there is the same 7 or 10 days. I think they moved it to. But what about those few percent who take longer before they become positive, and the incubation period is longer? So we'll see what happens. With that, keep you up to date. And the other one is if the slides would be sent out, and I don't know if we have an answer to that one. Do we get the slides for this one?
Yep. Casey will be posting those to our website. And you guys can check that routinely, and I will post a link to that in the chat here shortly. And we do try to routinely send those out as well.
All right. And anybody have any comments on what they're doing with the cohorting? And I know it's difficult in some facilities. Any brilliant ideas or a different way of doing things than talked about in the video? And if nobody,
Yeah, Dr. Dahl, I was just wondering if folks had any experience with the wandering patient as to how that's working out for them.
and I would say, what have you done about staff too? Because I know that's difficult when there's limited staff in and out. And have you been able to keep them to a cohort?
Yeah, I was just, I think I may have shared a recent study that showed that healthcare workers who are working on a unit, a COVID dedicated unit, they found in one study in New York that 27% of the staff did eventually acquire COVID, presumably through work on the COVID unit. However, it wasn't really clear whether they got it from the community or from the workplace. So those kinds of questions are still being, evaluated. But again, it just reemphasizes the idea of doing audits and monitoring, particularly on the COVID unit, for donning and doffing. Remember that the doffing is the most critical. When you take the equipment off, that's the most critical moment for contamination. So that's where the emphasis should be for auditing those moments.
And we do have somebody who actually shared in the chat what they've been doing. So I don't know if anyone wants to highlight that at all, or looks like Carly.
Yeah, I see Carly wrote in that if she doesn't want to talk, I'll read her thing to the group. They had to use the buddy system to make sure that the staff were donning and doffing their PPE correctly, because they didn't have enough staff to spare and to divide, right? So they just had to be really diligent with their use of PPE. Which I guess is you're not the only one, right? With how things are going right now.
And then maybe we can move to Michelle and team with the case study.
Sounds great. I'll let you take it away.
All right, this is Jean, and thank you, Dr. Dahl, for your comments earlier. I agree that everybody is in the thick of this right now, and I think that the information that's being shared is absolutely a good reinforcement for their practices. I'm just going to go ahead and read through the case study. Local, county, and state data reflect a rise in COVID-19 case rates and deaths in your county and its cities and towns. With community transmission rates near or over 10%, changes to COVID-19 testing protocols for staff and residents will be put into place. I'm just going to pause for a moment here and interject a side note. Recall in session 1, we shared a table from CMS assigning community COVID activity designations to counties based on positivity rates. And in this case, based on that information that we received, in this case scenario, this county would be assigned a high community COVID activity designation as their rate is greater than 10%. Now, if you don't recall this table, I just shared the link in to the CMS document in chat. If you don't know your county's positivity rate, it can be found by visiting your state's Department of Health website. And in addition to that, the CDC also publishes positivity rates based on the data that you submit to NHSN. I also shared a link for that in chat. So, okay, going back to our case study, in response to a community positivity rate over 10%, the administrator, director of nursing, and medical director have made the decision to limit visitation to outdoor visits only, to limit contractors and vendors to essential workers and deliveries, and all new admissions will be quarantined in a specially designated area or unit for 14 days or 10 if moving forward, once we hear that, regardless of their COVID-19 status. Next slide, please. Okay. So in the video, Dr. Schlifka laid out recommendations for cohorting 4 different strata of COVID-19 individuals. These were the confirmed, the unknown or the negatives, the exposed and the suspected. And as she mentioned in her presentation, all of these groups, each of these groups bring very special considerations to the table when cohorting. So the goal of cohorting, again, is to minimize risk of exposure and prevent additional spread. So as we go through the next few questions, I want you to consider whether or not your current cohorting practices actually accomplish this. Ask yourself that key question that she shared. Is what you're doing minimizing exposures or creating additional exposures? All right, we'll go to the questions now, and I'm going to ask you to share your responses to these questions by using the chat feature of our meeting platform or by unmuting your line and sharing. So the first question, in your center, do you know where to locate a room for any new admission? And the second question, in your center, do you have a COVID-19 positive unit or wing and an area or wing for residents who come in contact with a positive or with COVID-19 positive person and need to be under observation for a period of time? We'll just go ahead and let you type your answers to these into chat so we can have some discussion around them. Dr. Dahl, Faye, Michelle, while we're waiting for responses to come into chat, do you have any comments or information you'd like to share at this point?
Hi, this is Faye from North Dakota. I have been in meetings most of the morning regarding the new CDC recommendations for quarantining, and they are leaning on not having that applicable to the long-term care. Still waiting for final recommendations from them, but that is what they're looking at. And as far as North Dakota, that's what we are leaning towards as well.
Thank you, Faye. Okay, well, I'm seeing that most of the comments or responses that we've received in chat are yeses to both questions, which doesn't surprise me at all. We have one that says no to a COVID unit or wing. Faye, there's a question in chat that said, does this include staff also?
I just was reading that. Again, they are not final and we are working on our recommendations, but that is the way it is leaning.
Great. All right. Yes and no for number 2. So we've had 2 now that have said no to not having a COVID unit or wing and an observation area. And
I wonder if those units could just comment, is it you don't have a space for that in the building, or is it because you don't have very many COVID positive cases? Yeah, it seems like that's the case, is not too many positive cases, and so they're just limiting to their room. So I hope that stays the case for you guys. Best case scenario, right?
Yeah, I was going to just mention, Dr. Dahl, it seems like the, I want to say, hunkering down in place, for a room is similar to what Sanford is doing, is it not? Don't they have COVID patients that are pretty much off the COVID unit?
Well, we certainly have the hospitalized COVID unit that is all COVID positive, but there's certainly some stragglers that are out on the regular medicine floors for various reasons. And so, yep, there are those occasions.
Yeah, so it may not be an ideal situation, but if out of necessity that might occur. So just wanted to make that point.
very good. Thank you both for interjecting. I think we'll go ahead and move on to the next slide. So the scenario that we encounter frequently is bringing residents back into the center following a brief absence, such as a clinic appointment. And it was mentioned in the video, but Faye, I'm just wondering if you can take a minute to maybe elaborate on the recommended practices in this case. There seem to be a lot of questions around that.
Yeah, and a lot of new questions. We did have a federal survey in one of our facilities. Time doesn't seem to go fast enough during the pandemic, but honestly, I don't remember it was last week or the week before, but recently. And they were wanting to cite the facility with an IJ because they did not quarantine and isolate a resident that returned from a medical appointment. And so I did work with the Denver CMS office and tried to understand where they were coming from. And to my knowledge, that was finally not cited, but it is important to observe these people for 14 days. And our recommendation used to be 7 days. We just updated that and sent that out last evening. So ours will coincide with 14 days. And then of course, if they become symptomatic, moving them into a quarantine area until they are tested and get that test result back. But yeah, the surveyors are definitely focusing on this. And so the argument is that you should be using source control. So that resident should be wearing a mask when they're going out. When you're going to a medical appointment, we sure hope that those clinics as well are using source control with hand hygiene, screening, and masking. And so it's a controlled situation, just like them being in the nursing home with their healthcare workers wearing PPE versus a difference of being in a hospital overnight or for a few days coming back where they could have had a higher risk of potential exposures just because of the setting and not having that constant control of source control. So that was the argument, and CDC recommendation is to monitor, not to quarantine. And so my last I heard is that they were not going to get an IJ, but there is a lot of focus on how to handle these people coming back from ER visits, overnight stays, things like that. And to be honest, it's very confusing because CMS has also just put out their holiday recommendations which I'm sorry, for those in North Dakota that know me, I always err on the side of caution, so that I really struggle with this. But unless they're with their family for greater than 24 hours, the recommendation is not quarantine. So a lot of confusion, in my opinion, amongst the guidance of CDC recommendations and then the CMS holiday recommendations coming out, because you can go to a big family Christmas dinner and only be there 5 hours and be exposed by lots of people if there's no source control in place. But you don't need quarantine for that in their recommendation from CMS. But if you go to a clinic visit, they thought you should be quarantined. So that being said, can't debate the CMS. They are the regulatory, but that was an issue, and I use that comparison. But yes, you do need to truly closely monitor them, because we have asymptomatic healthcare workers out there as well. So there is still a potential for exposure, just like any other time, but hopefully with the masks in place and such, the risk would be lower. Sorry, I got off track there with that holiday. As you can tell, that still bothers me. So had to throw that in there. Sorry about that.
Yeah, no, I would just add that you're absolutely right, Faye, that it's all a proportionality of risk mitigation. And so if you have somebody that's 6 feet away and, fully masked, nose to chin, chances are pretty good they're not going to, get an exposure or get infected. But then, you never know when those slips might occur. So I think that's the whole thing. Do you treat everybody the same way, or do you have special circumstances where you say, oh yeah, but there was only me and my husband, and we had mom over for dinner. We're 6 feet away, and we all wore masks for the entire 6 hours. I'd have a pretty high comfort level, with that person, not having to be quarantined. But again, you have to go by standardized policies here.
Yeah, and that is our recommendation, that there is no black and white, and this is the rule. You need to look at what's happening. So like you said, if they're going to their daughter's house and it's just them and their daughter, and they know about source control, and that the daughter supports the belief, or are they going to a family gathering of 27 where they've flown in from all over and they don't believe in mask use and things like that. So yeah, the 24-hour time period, it just doesn't make sense to me. It's all about what's happening and where they're going. So
Good conversation. If anybody has questions that you'd like to ask Faye now, type them into chat. We have her ear. So I'll just go on and say that the effectiveness of any plan that we have in place hinges on the understanding of the how and why for everybody involved. And certainly these patients or these residents who are going home for the holidays, there's an opportunity for education with these families, and trying to encourage them to use the most reliable practices is very important. So in chat, you see the 2 questions there, and I already see that there are some responses coming in. These questions are in your center. Is there written information for residents, family members, and or partners about cohorting and visitation? And if there is this information easily accessible evenings, nights, and weekends? And I'm seeing yes to both of them, and I see one facility that's working on the packet. So I think everybody is on board with this. This concept. Team members, are there any other comments before we move on to the next segment? I see that we're kind of getting out of our time frames here.
I think we can maybe go on to the next section. I'm ready to go. If you want, Sarah, if you want to pull up the QI content. And we'll keep the chat open if you have thoughts or questions. Like Jean just mentioned, the fact that we have Faye on the line, we have Dr. Dahl and Dr. Geriatrics, we have these experts on the line that you have direct access to right now. So feel free to throw your questions in there and get that information answered. I'll just, because we're kind of running out on time, I will just quickly go through our QI content for right now. Yeah, and so why are we talking about conversation? The topic of this area is conversations to prepare for improvement. And we like using that word conversation because you're already having conversations with your staff. And that's really the most user-friendly way to build that long-term foundation you need, not only to keep your center going and respond to the coronavirus, but also gather information to assist in problem solving for today, but for tomorrow, as well as by including those folks and being part of that team together. We're working on an improvement to sustain joy in work and joy in our healthcare team. And study after study has shown that really that is what keeps your staff at your center, staying in their job. It's, you know, money is important, benefits are important, but feeling heard and recognized and part of a working team is really what keeps people engaged in their jobs. And we've been talking about improvement related to hand hygiene and infection control, but you can do improvement on anything, including how to make sure your staff stay, which is that's a crisis in itself right now. So we're talking about why we're having conversations. We would encourage you to use any opportunity to frequently communicate with your team members, you know, using those brief in-person huddles. You can use electronic methods, any approach to help promote staff well-being, to tap into their creativity, and ultimately that works to build a more robust system. Next slide. And this is just a pretty slide that shows us that we are preparing the ground for improvement by ensuring that our staff are heard, engaged, and an integral part of identifying and addressing issues. Next slide, yep. So there are 5 pillars of effective conversations. This is brought up is from this IHI resource that's linked on the bottom there. I believe we'll be sending that out. I'll also put the link in the chat box. But those 5 pillars are to hear me, where you are listening and acting on lived experience of staff to address concerns and support open and honest dialogue and problem solving. Protect me by reducing the risk of acquiring COVID-19 and transmission to my family as I'm a staff member. Care for me, provide support for team members and their families if they become ill or isolated, as well as understanding and provide resources to support secondary impacts of COVID-19, such as mental health support. Prepare me, provide training and ensure staff have honest and clear information regarding current state and preparedness to address current and future scenarios. And support me, acknowledge the demands of the current time and the limitations on what each of us can do. Encourage self-care and put in place support systems to ensure staff are able to care for their own needs. Next slide. And so, as I mentioned, we're supposed to be sending out this tool. There's a screenshot of it there, Conversations and Action Guide to Support Staff Wellbeing and Joy in Work During and After the COVID-19 Pandemic. And we do have a small amount of homework for you to just take a look at that first pillar, that hear me. And when you get this tool, if you just look on page 4, that's just the hear me area. That tool provides actionable ideas to test in these conversations, and it also provides some do's and don'ts to help enhance the feeling of safety and sustain joy in work. And so we'd like you to, just bring these 3 questions that are on the slide into the huddles that you're already having, or if you've got a small group, or even one-on-one. If you can ask these questions: what concerns do you have for residents, yourself, or the team? Are there steps we can take right now as a team? And what good thing happened today? Next slide. And so while you're asking those questions, practice some of those active listening and problem solving skills. So these are just some examples, and there's more cited in the tool, but here's what I hear you're saying. Do I have that right? Reflecting back what you're hearing from your staff to make sure that you actually are getting it right, but also reflecting that back lets them know that you hear them. What do we still need to learn, and how can we do this together? And last slide is our leave in action. So our homework is to try to speak to 5 staff members and ask them some version of those questions that we mentioned before. And we'd love to have you share some of that next week. Anything that you came up with new ideas that emerged from your problem solving, anything that was surprising. Love to have you share that when we come back together. I went through that really fast. Try and stay on task. So turn it back to you, Dr. Jurvich or Dr. Dahl.
Yes, Dr. Dahl, but I just wanted to slip in a thought here. Thanks, Michelle, for the homework assignment. And just wanted to follow up on that. So originally, when we asked everybody to join the initiative or the collaboration, that we wanted 4 team members and 2 backups. So certainly those individuals would be, I think, fair game for engagement. Of course, others would be welcome too, including the medical directors. I'll keep plugging for that. But yeah, that's going to be really important to continue that engagement with your team. So thanks, Michelle. And sorry, Lindsay, Dr. Dahl, back to you.
Yeah, no problem. I appreciate it. Unless anybody has comments, we'll kind of just talk about summarize things here and get you on your way, because I know your time is precious. So basically, know where to find your policies and procedures, especially for cohorting when you have suspected cases and positive cases, and when people are coming back to quarantine from being out and about. And yeah, what to do with new signs or symptoms. And don't forget that one of the most common symptoms in our frail older adults is the delirium, the lethargy, the change in cognitive status. So don't forget that, and educate staff about that. Have a training education plan for COVID units. Continue to observe and make sure people are following the rules and understand what the plan is, especially because we change the plan. It seems like almost every week, but at least in the hospital. So just keep communication open. Describe the process of how to interact with all residents and staff if there's a COVID outbreak or suspected outbreak when tests are pending. All right, if anybody has any comments, we'll hang on a little bit here. If you need to get out of here and get to do some other things, we'll let you go.
Hi, this is Cindy from Wishick. Yesterday we had the first survey in North Dakota, infection control survey with the new guidelines. And absolutely everything that was said today are questions that were looked at, that were, they asked for policies, procedures. They asked about cohorting. They wanted to know what our plan was. They talked about testing. Everything that was talked about today was reviewed yesterday in our survey.
And no doubt you were like a shining star.
Actually, we're very happy to say we had no deficiencies.
Yeah, that's as predicted. So congratulations.
There was a question though, and Faye, I'm gonna throw it at you. One of the things that they told us that we absolutely have to be doing is when we're donning, we have to sanitize in between every single step.
Are you redonning PPE?
If I'm going to go into my COVID unit from my desk, I am going in, I'm going to sanitize, and every single step, everyone, anytime they're doing PPE, whether they're donning or doffing, they're supposed to be sanitizing every single step.
Okay. And they may be saying that because there's so much reuse of PPE for people going in and out between units, and we do recommend that. So if you're coming from the quarantine or the non-COVID units and then going into that unit, or if you're coming from COVID and then going to work another area, that is the appropriate protocol to be doing the hand sanitizing between each step.
Okay.
Is that what they were specifically talking to you about? Because you had people going back and forth, or?
They talked about like the isolation unit. They talked about the COVID unit. Anytime we're donning and doffing PPE, this is what we should be doing.
Okay. I'll check into it further.
They also told us that we are supposed to be disposing of our mask every time we come out of our isolation unit. We have a mask and a shield, and we should be disposing of that mask and putting a new one on. I don't have an abundance of masks floating in my basement.
Yeah, that isn't our recommendation based on our PPE supply. We recommend that it's discarded for reprocessing at the end of the shift, unless it is known contaminated or you've been doing aerosolization. But yeah, I can check into that more.
Thanks.
Could have been something they got from federal. So I'll check into it, see what I can find out.
Okay, thank you.
Yes, it looks like there's some other additional comments regarding that same thing in our chat.
This is Corrine calling from International Falls. I'm talking under Carrie's name here. We recently received a lovely IJ tag from the State Department, and we were told that if you are short or don't have a, let me reword this. If you have adequate supply of gowns, you should be one and done. Every resident, you wear it one time and then you dispose of it or you launder it. And there's no exception to the rule. Same with your mask. If you're going in an isolation room, one and done, and it should be disposed of unless you are in where you don't have enough supply. But they never gave us guidance as to how much supply should you have on hand to be considered not enough supply.
Yeah, I would just respond to that. Is my understanding that if you're less than 2 weeks burn rate, then that's the reusable moment. So I think maybe that's one of the responses that you would have.
Okay, thank you.
Well, I have to hop off to see some patients, but thank you, everybody.